Hopefully that's all right. It's recording. So I want to thank everybody for coming. We've been trying to do throughout this crisis
Wally Carter.
Tuesday night, a little kind of residency social. If you guys don't mind, if you could just mute your mic if you're not talking, just so you can hear some of the other people. We have two really special guests tonight, Dr. Paul Gennis. Wave, Paul. Dr. Paul Gennis was class of 1981 and was chair at Jacobi for many, many years, residency director as well. Good friend and mentor to basically all Jacobi grads. And then I actually conned Wally Carter, class of 1991, to come join us as well. So you can wave to Wally as well. I thought it would be really special to hear from some of our old Jacobi old-timers, just kind of what old Jacobi was like, and then also what it was like a little bit during the crack wars and during the HIV crisis, because I think that's probably the most analogous episode to what we have going on right now. So I guess, Paul, why don't you let Dr. Gennis start, and then Dr. Carter, if you want to jump in a little bit, and then you guys can ask questions and say hi. And I see we've got a spy there. I see Demore. He snuck in. What's up, Jason? Jason was one of Dr. Carter's residents down at Bellevue once upon a time. So
look, again, I'm Paul Gennis, and the first thing I want to do is thank all of you guys, including Wally, for being there on the front lines despite the risk. I think it's a real testament to your bravery, and it makes me proud and makes me proud of the program. Mike asked me if there was anything comparable to this coronavirus pandemic that we experienced, and that one's easy. No, nothing even close. This is totally overwhelming. I mean, if you think about I guess the closest thing that we experienced to the coronavirus, it was the AIDS epidemic, which came to us in about 1981. 1981, I guess that was about a year before Wally got there. Is that right?
Well, I was there in '77 as a medic, so I was there.
Doesn't count. Okay. Yeah. Anyway, so back then we started seeing things that we'd never seen before, like PCP pneumonia, like Kaposi's sarcoma, people with toxoencephalitis. And the similarity is that there were so many patients. The difference is that the AIDS epidemic back then, or AIDS was a fatal diagnosis 100% of the time. Someone could come to the ER and stubbed his toe, and while you're evaluating the toe, you notice that the patient has a little oral thrush, and you knew that that was a fatal discovery, you know, and you had to decide whether you're going to enter into that conversation about, look, you got 6 months to a year to live, and, you know, and your toe's broken. So it was kind of a remarkable time. And for us on the provider side, we our biggest fear was needle sticks, and we were terrible at dealing with sharps in those days. There was no such thing as a retractable needle. People, I would say, we would see a needle stick from a resident somewhere on the order of once every 2 weeks. And, you know, it was a devastating feeling to get a needle stick from something that's 100% fatal. But I will tell you that over the years, no resident at Jacobi or at Montefiore ever got AIDS. No one ever got AIDS from which was good news. Wally, you remember the AIDS epidemic?
Well, I remember I can't remember if it was 55 or 65% of the medical service at any one time was HIV and AIDS, and medical service and almost all of was Carol Harris's service over at Van Etten was nothing but AIDS, and it was patient after patient after patient. It was kind of it was almost refreshing to see somebody with pulmonary edema come into the ER because it was crushing. And as you said, we didn't know for a long time. We didn't know what it was. We thought we were actually greater risk to the patient than they were to us. We didn't quite understand. There was a period of time when you went to see an HIV patient over at the college or whatever, you'd gown and glove the same way you would now for PPE for Corona. And then we kind of quickly, not so quickly, figured out that wasn't the right way to go. But it was all encompassing. It took over everything we did.
Yeah, in the late 80s, when AIDS was still a fatal disease, just when we thought it was safe to come out of the water or go back into the water, along comes the crack wars. And I think what really characterized the crack wars was the fact that you no longer saw a gunshot wound to the abdomen. You would see 4 gunshot wounds to the abdomen, multiple holes in every single penetrating wound patient that we saw. And it got to the point where we were seeing so much penetrating trauma, especially gunshot wounds, that, and by the way, it's all from automatic weapons. That's why we were seeing so many multiple gunshot wounds. But we saw so much of that we started to worry as educators that our residents were not going to get enough experience in blunt trauma, car crashes, or single penetrating wounds. So it ended in the early 90s. And it really ended, in my opinion, because many of the young crack dealers wound up killing each other. And it was like there was no one else to battle with. So we saw fewer and fewer gunshot wounds after that. If you like, I mean, you can ask questions, and Wally and I can try to do our best to answer. Or, I mean, I could schmooze for a little while and just to talk about what ER life was like back when I joined up in '79. What would you prefer?
Paul, can I ask you? I would love to hear what the emergency department was like back when it was not the emergency department; it was the ER. And then I'd also love to hear about what you think this epidemic is going to do to the future of emergency medicine, having seen some of these, wild and crazy times in the past and how they affected the practice of medicine.
Well, I don't know if I can answer the latter question, but my guess is that what it will do, it will help us become more prepared. I mean, if there's a devastating problem that we're all dealing with now, it's because we were poorly prepared, and we shouldn't have been. There were agencies in federal government that saw everything that's happening and predicted it, and those agencies were dismantled. And at this point, we have to play catch-up ball. And as everyone has pointed out, especially Fauci, you can't win this with catch-up ball. It doesn't work. Any comments, Wally?
Well, yeah, I mean, this is interesting. I think it's, on some levels, I think the people from outside New York looking inside, are kind of stunned at what we're seeing. But I mean, for me, I think this is an incredibly, if you were earlier on in your career and you're thinking about doing a PhD and you wanted to do a dissertation on healthcare disparities, I think this is an absolute casebook, kind of a case study in healthcare disparity. I mean, I think it's interesting that Elmhurst has been on the news as much as they've been on the news. I mean, let's be honest. I mean, there was a period of time when people used to say when they wanted to go to the country, they'd go to Queens. And it was a sleepy little borough, and there were 2-family homes and 1-family homes, and people would commute into the city. Sometimes they wouldn't. And over the last 20 years, it has become a densely populated borough with a heavily immigrant population. And at the end of the day, Elmhurst Hospital is still about the same number of beds as it was back in the 70s. It's about the same size as Lawrence Hospital in Bronxville. and that nothing in the city administration over the last 30 years have they done anything about it. Healthcare in Queens was barely able to care for itself on a daily basis, let alone a surge that we're seeing with the current crisis. So I think it, as Paul said, I think it was predictable. And I think I think what you're seeing is, again, great case studies in health disparities. We're seeing places that are not able to cope and places that are coping quite nicely because they have the resources and the wherewithal to make it happen. And I think that's just been a chronic issue within our healthcare system. And I think it's something we're going to have to. We've certainly talked about it in the past. Every time we do one of these things, I mean, I spent a month down on the Gulf Coast in Katrina, and all we talked about was transportable licenses and being able to do this and get things down. And I don't know, that was '05, so we're 15 years later. Some things have changed, but it certainly hasn't changed to the level of nimbleness and flexibility that you would need to be able to, respond to something that's happened to us over the last four. I mean, really, you think about this is really literally over the last 4.5 weeks, and we're just not flexible enough to be able to do it. More importantly, we weren't prepared to be able to move things into where we needed to move them. So it's it's a little depressing, but I think there are an awful lot of good stories that are coming out of this, and an awful lot of incredibly positive and just very things that we should be proud of for being emergency medicine docs. I've been doing this for a long time, but I just finished 7 shifts in 8 days. I actually would give a lot of money to have resident duty hour protection right about now, but I don't. But I got to tell you, I go into that ER every day, and I hang out there with the residents, and I am incredibly proud to be an ER doc, and I'm incredibly proud of the training I got at Jacobi. And I think I'm probably doing better than most, probably because of being on Pelham Parkway. And as Paul said, living through the crack wars and living through HIV. And so, I mean, I think that, on some levels for you guys that are coming into this, I think this will be part of your legacy. I mean, you will have lived through an incredibly difficult period, but you'll come out on the other side and come years from now, there'll be another crisis, and you will be able to look back and say, well, we got through it, and here's how we got through it. And you'll be the next generation of leaders. So I'm optimistic. I think it's painful, but I'm feeling pretty good about the specialty, and I'm feeling pretty good about what we stand for.
Remember,
So, sorry, I just one of the questions from one of the residents, Linnell Campbell. She was asking, obviously this pandemic is far more negatively impacting minority communities, the poor communities. What do you guys think we can do, and what did you do back in the past to help support our community, and what can we do as residents and then new faculty to continue to support our Bronx community?
Ooh.
Sorry, not an easy one.
Let me just reflect way back to when I used to work in one-man ERs before I did my training. I mean, back from 1975 to 1979, I worked in one-man ERs. First for 2.5 years down in Harrisonburg, Virginia. This is with an internship behind me. I knew everything, just so you know. But I spent 2.5 years doing.
Don't worry, our interns still think the same.
All right. One-man ERs in Virginia, and then I went out to join the Fisher Mangold group in California, where I worked in one-man ERs out in Turlock, California. Turlock, whenever I admitted a patient, I had to check to see whether they had Medi-Cal. Medi-Cal is California's version of Medicaid. Okay. And if they had Medi-Cal, I had to make a phone call up to the county hospital in Modesto and ship that patient up to Modesto because of means testing, because of what their insurance was. And their insurance that didn't pay as much as the commercials. When I came to Jacobi, one of the first things I said in my interview was, I don't want to do this anymore. I do not want to ship patients to public hospitals in order to get them admitted. I want to work in a place that takes care of all patients regardless of ability to pay and provides excellent care. And that's what Jacobi was at that time.